Hello and welcome to Basic Cardiac Monitor Interpretation Review. So what we have in front of us is a little application on my iPad called Dart Sim, and I really quite like it to assist people with rhythm identification and how to manage those arrhythmias. So let's start here with our rhythm keypad and start very basic normal sinus rhythm. You can see there is a P in front of every QRS. The QRS is slim. If we measured the PR interval, I bet you it would measure at less than 0.20 seconds. And when we look at the QRS, it's quite slim, so we know that the conduction has gone through the AV node and down the bundle branches and terminated at the Purkinje fibers. Then we see the T wave, the QT interval, if I were to measure it, would be less than 0.44, less than or equal to 0.44 seconds, and everything looks very normal. This is a patient, I suspect, who is not on telemetry, but in order to know that there is mechanical contraction associated with this electrical activity, we would want to check a blood pressure. And so we click on the patient's NIBP and it will pop up. We would also like to have a saturation. So let's give this patient a good sat. They have a great blood pressure. So you can see that the pleth or the waveform of the sat monitor correlates with the ECG rhythm above. And so this is sometimes referred to as a poor man's art line, because when the artery has low blood flow, then you will see a change in this waveform. So if you had a really low blood pressure that would give you poor perfusion to your digit, then you would see a very small dampened waveform. And often when the patient is hypertensive, you will see a tall waveform. So use that to your advantage when you are assessing patients. If you look here, we will give our patient a respiratory rate. And if this patient had some way of measuring his exhaled carbon dioxide, then it would read as a waveform up here. And a normal CO2 level for exhaled air would be between 35 and 45. And so when we see this patient, we see a very normal patient. We would even have a temperature, and it would likely be 37.0. And so here is a great picture of a very well patient. If I wanted to do a 12-lead ECG, I could click here and I would see my ECG. For those of you that are not familiar with reading ECGs, this is basically 12 cameras centered around the heart at different angles, and it gives you 12 different pictures of this patient's cardiac image. At the very bottom down here, where I am moving my mouse around, that gives you a continuous lead to rhythm strip. So this here should correlate with what is up on your patient's bedside monitor. So we think that looks pretty normal. Let's close this. And if I wanted a chest x-ray, then I could bring this up. If you look at chest x-rays, air is black, fluid is grayish or whitish. And so this patient has a lot more white than he does gray. I suspect he has some signs and symptoms of pulmonary edema. And so there is a look at sinus rhythm. If we slow that rhythm down to below 60 beats per minute, like this, you will see my alarm is ringing. I'm going to turn that off right now. But I wouldn't do that in the real world. I would allow my alarm to continue. I may decrease the sound in front of the patient, but you would never turn an alarm off unless you were directed to by a physician who is standing there beside you with the patient. Sometimes we just decrease the sound so that it's not so alarming for the patient. But when I look at this patient, I see that his heart rate is much lower than it had been. It had been 70. And a heart rate of 38 is really going to depend on the patient condition. So you cannot determine how stable or unstable this patient is by simply going and looking at the monitor. You are going to have to look at the patient. You're going to have to do an assessment. And when I do that assessment, I need to go in and look at my patient. I need to talk to him. I also need to assess a blood pressure. And as I do that, I'm going to apply a blood pressure cuff and I'm going to feel the patient to see if he's warm and dry or if he's cool and clammy. So let's check a blood pressure on this and telling me that he doesn't feel that well. And you see that his SAT has dropped. You see he has a low blood pressure. So I can determine from this that my patient has a symptomatic bradycardia. And when I think about my treatment options, if I had an order for atropine, then I would go to my medications. I would find atropine. I'm going to give it IV push. I'm going to give 1 milligram and I'm going to administer that. And what I would expect to see is my patient's heart rate increasing significantly. And I would be chatting to my patient. I would be asking him if he felt better. And at the same time, I would be checking a blood pressure. I think I'm going to give some supplemental oxygen. And I'm going to give him a couple liters of nasal prong. And look, my atropine has brought up my heart rate as well as my blood pressure. I have provided some supplemental O2 and I'm looking to get my SAT up somewhere around 92 to 94%. And so my patient is looking much better. When we look at the rhythm sinus tachycardia, we should think sinus tach. Why is this patient in sinus tach? And we talked about in class that there were really 4 reasons that your patient was either hypovolemic, could be potentially anxious, could be having pain, could be having a lot of anxiety or fear, dehydration. But in this example, we are privileged to know the history that this patient has received a positive chronotropic drug. And the word chronotropy refers to how fast or how slow the heart goes. So atropine is a positive chronotropic drug. Now, I would suspect over the next 30 to 45 minutes that my patient's heart rate will slowly come back to a normal sinus rhythm state. Now, we also have to determine why the patient developed symptomatic bradycardia, but that is after the fact. We need to manage the patient because he was unstable, and then we have to investigate why did this happen. So that is our first kind of look at a patient. Let's look at another patient. Wow, this is a very, very rapid. In the real world, your PLEP on this SpO2 would be moving as fast as this heart rate was. It probably doesn't pick up very well because perfusion to your digits where this SAT monitor is placed is not really picking up. And so you see it's alarming 0 right now. I need to go in and look at this patient and assess him very, very quickly. So I go into his room. I never run, but I go in very quickly to see if my patient is responsive or not. And he looks at me. He's very diaphoretic. He has a very scared look on his face. And I offer some positive reassurance that my name is Sue. I am your registered nurse and I am right here with you, sir. I do not panic, but in a very expedited fashion, I am going to put his blood pressure cuff on and I am going to check his blood pressure. And I see, wow, it's 67/33. He is very symptomatic. I need a physician here quickly. This patient is not a candidate for rhythm and rate altering medications because he is considered unstable. And if you think about the tachycardia algorithm, the management of unstable tachycardia, whether the QRS is skinny in this example, or whether the QRS is wide, and one that we'll look at shortly, synchronized cardioversion is indicated. And so my physician has called me, he's on his way up and says, prepare for synchronized cardioversion. So I say to myself, oh my gosh, say it isn't so. O stands for oxygen. Well, I'm going to call my RT and ask if they can come and assist with cardioversion. And then I am going to connect my patient to the defibrillator. Once I have the defibrillator on with the ECG electrodes and the defibrillation pads, I'm going to hit the sync button. And you can see that there is a marker over top of every QRS. And that tells me, the defibrillator operator, that this device is sensing electricity or sensing intrinsic heart rate so that the electricity can be delivered on the R wave and not on the patient's T wave, because we want to prevent that R on T phenomena. And so, oh my gosh, we always say who a gosh is, or sometimes we say God, who thinks they're God. We need a physician to give us direction on how many joules of electricity. And so my physician has given me an order for application of 100 joules. So then we say it isn't so. I want to make sure I have suction in place. The first I stands for intravenous. I want a patent IV in case my patient digresses further. I would like to have intubation equipment readily available in case they digress. And then the last S is sedation. And sedation is very dependent upon patient condition, how stable or unstable they are, and what the physician's previous experience with cardioversion has been. This patient is quite symptomatic. They have a significant decrease in their level of consciousness, and the physician has said, let's not provide sedation. And so we are going to tell the patient what they're going to expect. Right now, my patient is barely conscious. So I'm going to hit the charge button and I'm going to recite, I'm clear, you're clear, we're all clear. And we are going to shock delivered. That patient has, alarm has quieted down. We have a different rhythm. Anytime you have a different rhythm, you need to check a blood pressure to go with that. And so very quickly, you would hit the NIBP button, and your patient is much more alert and awake. Got supplemental oxygen on, and you can see that his saturation is 95%. You've got a much better blood pressure. And so synchronized cardioversion took that patient from an SVT down to a nice normal sinus rhythm. So let's go on and let's look at a patient with third-degree heart block. And third-degree heart block is almost always linked to some underlying pathology. And when we think about this, oftentimes it can be drug related, but more so, especially in the New Brunswick Heart Center, it is often ischemia related. So there is ischemia to the AV node, and you can see that the P's are working independent of the QRSs. There is no correlation between the upper chambers, the atria, and the lower chambers, the ventricle. The other thing, well, the two things that I find alarming about this rhythm is first, the heart rate. Heart rate's only 36. So again, I want to check and see what my patient's blood pressure is. So very quickly, I check a blood pressure. See that their saturation is okay for now. So I look at my patient and he has 2 liters nasal prongs on. So I'm going to leave that 2 liters. And I'm also concerned now when I see that low blood pressure. So this patient is unstable. Also, I might have an order for atropine, but atropine is likely not going to work in this scenario when you have high levels of AV block, such as second-degree heart block type 2 and third-degree heart block. Atropine is often ineffective because it doesn't activate the vagus nerve, because the vagus nerve sits above where this ventricular impulse is coming from. And so I need to pace my patient. And so as a critical care nurse, I can do this without a physician present. I will often call them to let them know that the patient is unstable and has gone into third degree heart block, but you can initiate pacing on your own. And so you're going to put the defibrillation pads on the patient. Those are called quick combo pads. And the combo means that you can defibrillate, cardiovert, and pace all with the same pad. You also need the ECG electrodes from the defibrillator attached to the patient, even though he has the bedside monitor electrodes attached. It's just like cardioversion. Whenever the machine needs to sense the patient's intrinsic rhythm, you need to have the ECG electrodes on the patient that are connected to the defibrillator. So I have put the quick combo pads on, I have put the ECG electrodes on, and I'm going to come and I'm going to turn my pacemaker on. And you can see that there are some spikes here that are not followed by QRSs. This is called loss of capture. And what this means is we have to give more energy or milliamps to the pacemaker. So if you look down here, you can see that the pacemaker is set at a rate of 60, but it only has 5 milliamps. So I am going to increase the number of milliamps. I'm going to go up. This device goes up by 5. And I'm going to continue to go up until I see a spike followed by a wide QRS continuously. And as you can see on the monitor here, we have a spike followed by a wide QRS. That is electrical capture. And then we need to assess that the patient has good cardiac output from that by checking a blood pressure. And so you'll simply hit your NIBP, you will inflate the blood pressure cuff, all the while you are comforting the patient. This could potentially be causing some significant pain. The thing with pain is oftentimes it will help increase the blood pressure. And in this patient, it didn't increase the blood pressure. Patient still is hypotensive. And sometimes when you pace somebody, you are only pacing their ventricle with this type of pacing. And when you lose the atrial contraction, you lose something called atrial kick. We talked about atrial kick on Tuesday of our BCMI course, and we said that atrial kick was that last little bit of cardiac output that occurred from active atrial contraction. And it usually happens, or it does happen when the atria contract at the end of atrial systole, and it gives a boost of between 20 and 30% to your cardiac output. This patient is not receiving that because he is what's called VVI pacing. The first V stands for the chamber that is being paced, that's ventricle. The second V stands for what chamber is being sensed. The only thing that this pacemaker is sensing is it's looking for intrinsic QRSs. It does not have the ability to look at intrinsic P waves. And if it sees ventricular contractions at a rate faster than the pacemaker is set at, so ours is set at 60, then the pacemaker will sit back and inhibit. And when you look, let's say this is our patient right now, and then all of a sudden this happened. And you wonder, where did the pacemaker go? Well, the pacemaker is still there, but the patient's own heart rate is 70. The patient's pacemaker is set at a rate of 60. If the patient's heart rate were to drop to 60 or below, then the pacemaker would kick back in, and that is called demand pacing. So an external pacemaker is a VVI pacemaker. All it does is pace the ventricle, but that will give you some cardiac output. If this patient remained to have a low blood pressure, then we may have to look at supporting his blood pressure with either fluid volume, or we may have to add a vasopressor. And the most common one that you would see in this patient population is norepinephrine or Levophed. And so let's go to STEMI patient. So here we are, new patient, and I want to go in and look at him. Sorry, I'm just going to reconnect my remote here. And so first thing I want to do is I'm chatting to my patient. I want to check his blood pressure. And I'm asking him, sir, are you having chest pain? How do you feel as the blood pressure comes up? When I'm looking at the chest elevation on the monitor, sorry, let me just reset this. There, let's check a blood pressure now. And I would like to have a 12 because, oh, sorry, I'm not sure why the blood pressure is not resetting. Let's try it again. But I want to do a 12 lead. And in this, I see there's ST elevation in lead 2, lead 3, and AVF. In this particular example, this is an inferior STEMI because these contiguous leads have ST elevation in them. If you haven't taken a 12-lead ECG course, it is offered through the New Brunswick Critical Care Nursing Program if that is something that interests you. So this patient is having a STEMI. His blood pressure is 120 on 67. I want to see what his SAT is. And basically anybody with chest pain, as long as their SAT is greater than 92, then we're pretty happy and don't get too worried about supplemental O2. And so this patient is in St. John. I am preparing him to go to the cath lab. And all of a sudden, he goes into this rhythm. Can you see how his SAT went absolutely flat? That's an indication that this rhythm has no perfusion to it. You would do a quick pulse check. You have no pulse. So your colleague has started CPR. And if you look up on the monitor, this is what you see when somebody is doing CPR, unless you have a fancy monitor that gives you what we call see-through CPR. And so CPR is happening at a rate of 100 to 120, and I am connecting my defibrillator. So I'm putting the quick combo pads on the patient. And you would look at the manufacturer's recommended amount of joules in St. John. We would go to 200 and we would hit charge. CPR would stop. You would see he's still in that V-fib rhythm. We would shock. We see the patient has come back in an ST elevation rhythm, but the first thing we need to do is check a blood pressure, check and see if he's got a pulse. Does this patient have any pulse? Yes, he does. The patient's talking to me, and I have a good blood pressure, and he's chatting away to me. And this cat is picking up again, asking what happened. He's very scared, and I'm getting ready to take this patient to the cath lab. I am not going to leave the emergency department or the CCU department without my patient being connected to a defibrillator, because the patient is very likely to fibrillate a second time before we get a PCI into this patient, before we start to revascularize him. So that is a little bit of a review. I'm going to do one more rhythm, and this is a new patient. So let's hit reset here. And I want you to look at this rhythm, and I want you to see how it is very up and down, twisting of the point. You see it's down, then it gets narrow, and then it's up. It gets narrow and it's down, narrow and it's up, narrow and it's down. This is very classic torsade de pointe, P-O-I-N-T-E. Do not be fooled on your test if it said torsade de paint. That is not a rhythm. I don't even know where that comes from. So be careful when you're doing your online test. But this is a patient. I quickly go into his room and I do a quick pulse check. There is no pulse, so I am going to initiate CPR. So you can see that CPR almost looks like ventricular tachycardia, but when you stop the compressions, you see the torsade is underneath. So we're doing CPR. We come to our defibrillator. We put the defib pads on. We're going to go to 200 joules. We're going to hit charge. We stop doing CPR. The person delivering the shock says, I'm clear, you're clear, we're all clear. Shock delivered. And we are back to a sinus rhythm. When we have a change in rhythm, we immediately do a pulse check. This patient has a pulse. And we would immediately do a blood pressure. His stat has come back. And cough. So we were able to defibrillate that torsade de pointe. And that is it. I hope you have a great day, and thank you for your attention.